after 4 liters, you should be going to CPAP as opposed.
Okay, so this is what is said, because what they suggested, I partially took it from that publication,
Yeah,
the French publication,
which was very good, by the way.
Yeah,
that
okay.
German one. Yeah.
Yeah, yeah. Okay, so then we'll keep it at 4. Okay.
Yeah.
We'll keep it at 4, and optional at 6, or just after 4 go into.
I think 4. I go to CPAP.
Okay.
Yeah.
Okay. Good.
Yeah. Certainly, at our hospital, 4 liters is a trigger to like start thinking about ICU type of thing. So.
Okay. Yeah. Yeah. Okay. So then pronation. Any comments on pronation?
Pronation. Yes, it can be done even with non-invasive ventilation. You're talking about, heading towards 16 hours a day, but usually as bouts of 3 to 4 hours with a break, as not a continuous 16 hours.
You don't suggest continuous. Okay.
No, most people seem to be doing it. It seems to work better if you do it in, bouts of 3 to 4 hours.
What I would suggest, for the sake of time, that we'll have, I'll show the slide, and then we'll just comment on the slide instead of just reading it, and that will help to avoid translation.
Yeah, I think that's fine.
And then again, 2-3 sentences, and then a short break so that they can keep up.
Yeah, sure.
They are not, just to emphasize, they are not professional translators. They are just master and doctoral students, and they help. So obviously they have medical degrees. And,
right.
У нас не профессиональные переводчики, а это докторанты и магистранты.
I will just mention something else.
Я хотела бы еще кое о чем сказать.
Okay, they're checking something. I will need to.
Sorry.
Okay. Okay, so any other comments on the slides?
No, I mean, yeah, but I think that article is really quite good. I think I would send this to them, because it was also good to see a bit of, there was an overlap between the different sections, and they didn't totally, agree, but in some ways it's good to get a real spectrum of opinion.
Okay.
It was very thorough.
What I'm thinking is, because we have this YouTube channel, we can potentially post it there so that people can.
There might be copyright.
That's right.
I think you can, maybe provide a link or something like that. But if you put up the paper.
Yeah, that's true. That's true. Yes. Yeah. Below the YouTube video, there is a section for comments.
Okay.
We can put the link. I really like the article, so I took. And as you see, even within the same panel, there was a lot of disagreement.
Yes, that's what I thought was healthy, is that there was, each. It was funny because I thought each statement would cover a different section, but they overlapped. And they didn't necessarily agree, which was fine, but I think it gives in some ways, a more realistic view of the current understanding, because it really, people are still trying to figure out how to do things. Although it looks like intensive care survival is improving. I think it's because people are being more selective about who goes into the intensive care. And also a little smarter on how they're ventilating and all this, and preventing complications.
So I've been told that they're checking the YouTube streaming, because before there was some lagging of the signal. Let's see. I'm waiting for a confirmation from my colleagues that we can start.
Okay, which slide are you going to start on?
I will start with the summary. with the summary, because we'll just pretend it's the same session.
Okay,
yeah, I'll just.
So which slide number, just
yeah,
so
yeah,
I can.
Yeah. I will. Synopsis. It's the 19th, 19th and 20.
Oh, so we're really, really, really way behind. Okay.
What I suggest is that we'll show just some slides and then a couple of comments, and then we'll continue so that we'll have like I would say less than 7 minutes per section. So
okay,
because there is no need to read the slides, because they can read it. If they will have questions, they'll ask.
okay.
Okay, can someone give us a confirmation that we can start? Something else, since we have someone, a different person who will be translating today, there will be an introduction saying that there is a new person translating, and after this, I will take over and we'll start as if we're continuing.
Okay.
The section. So can we start? Okay, so I think we can continue. And with this, we'll have a short intro to have a new translator introduced. Please.
Good morning, everyone. Hello, everyone. Біз талқылауымызды ары қарай жалғастырайық. Ағылшын тілінен аударманы екінші жүргізуші Әл-Фараби атындағы Қазақ ұлттық медицина университетінің медицина және денсаулық сақтау факультетінің іргелі медицина кафедрасының оқытушысы ангиохирург, флеболог Балжан Айдашева жасайды. Мы продолжаем нашу дискуссию. Перевод с английского будет сделан нашей второй ведущей Балжан Айдашевой, преподавателем кафедры фундаментальной медицины факультета медицины и здравоохранения Казахского национального университета имени Аль-Фараби, ангиохирург, флеболог.
Thank you, Sambat. So I will take over. I will again put my slides on the screen. So just to have a quick summary of what we had during the last part of our conference. So we just spoke that severe COVID-19 is less frequent in pediatric patients. And that it can manifest differently. We discussed briefly the Kawasaki-like syndrome. And here is the slide translated. So I will, for the sake of time, I will just stop very briefly on this interesting topic on what are the predictors and what are the definitions of severe COVID-19 in adult patients. So again, for the sake of time, there is no need to describe all these criteria. I'm just putting the slide on the screen. And what may be more interesting is an introduction of this online calculator to define the ratio between the partial O2 pressure and the fraction of a inspired O2. And I checked this calculator this morning. It works if you put here the numbers, the estimates for FiO2, and press the button calculate, you get a number which will be hopefully above 300, indicating that this patient does not fit the criteria for ARDS. But if the values are below 300, then here is the breakdown of the severity: mild, moderate, and severe. So I encourage everyone, here is the link to the website with this online calculator.
I'll just add that often a threshold for severity is 150. So below 150 starts to be quite worrisome and usually needs more intensive support.
Okay. So you're referring to this last line in the table. So
yes.
You would consider 150.
Yeah.
Okay. And then we also discussed this section about comorbidities and the risk groups. And again, no need to discuss this in detail because information is available. I specifically put the information as detailed as possible so that our audience won't need to we won't need to stop discussing these slides. And then we wanted to introduce another online calculator, which takes into account various risk factors and clinical manifestations, including demographics such as age and laboratory features. And that puts, it's a paper published in JAMA Internal Medicine, May 12th this year. And that gives online calculator. I went online to check this calculator. I went online, this is the website, the link to the website. And if you put the age or various comorbidities, and as comorbidities, they consider it COPD, chronic obstructive pulmonary disease, hypertension, diabetes, coronary heart disease, chronic kidney disease, cerebrovascular disease, liver disease, and various immunodeficiencies. Adding the various laboratory parameters at the end, this website calculates the presumed risk. So with this, I think we can continue. So we addressed this before, so I will just show the slide so that people will be able to read it. And this is the actual topic that we wanted to discuss in more detail. So last time you mentioned that you would not only consider doing pulse oximetry, it's also important to check for involvement of skeletal muscles in the breathing process. So anything else that you would like to emphasize on this?
I think as well, and it was on the previous slides, about monitoring respiratory rate, especially in adults going above 30 is a worrisome sign. And similarly, something that's easy to evaluate in terms of response to therapy of oxygen or non-invasive, such as CPAP or BiPAP, that again, if the respiratory rate is not going down, then the intervention is not viewed as being helpful.
Okay. And we, before resuming with our session, with the second part of our video conference, we briefly discussed prone positioning, and this is a simulated photograph that shows a patient in a prone position. Can you please explain us what do you think about, what's your opinion on prone positioning the patient and how this helps physiologically?
Okay, so prone positioning was first developed for adults with ARDS. The concept is that that it supports the abdominal muscles. It helps raise the diaphragm, and therefore the diaphragm can be more efficient in terms of its ability to generate negative pressure and take in breaths.
Some people also say about the increased involvement of dorsal alveoli, which when the patient is lying on their backs are not involved in the breathing process.
It's certainly well known that the dependent regions are not as well ventilated. And the height, which is from the front of the chest to the back of the chest, is larger, certainly in adults than children. And so there is more pressure on the dependent regions. And so to recruit the base of the lung lying on your stomach and being prone will allow those areas to be recruited.
That's an excellent comment. Do you think someone with obesity will have additional problems, not just because of their disease, but because of the weight of the chest weight?
So the weight is not only chest wall compression, but also abdominal compression. And this very much can lead to lower lung volumes. They also may have fat in their small airways, making them narrower. And so obesity, you're prone to airway closure, and that can lead again to volume loss, particularly in dependent regions.
Okay, that makes sense. And we also discussed briefly the potential recommendations for the duration of this pronation.
So prone treatment seems to work well when you can achieve somewhere between 12 and 16 hours a day. But what people have found is that rather than doing it as one straight session, is to break it up into sessions of 3 to 4 hours, so that the 16 hours are achieved over 24 hours.
And breaking means that you put a patient in a lateral position or on their backs?
Yes.
And for how long this break would be?
So then the break would be probably for 1 to 2 hours.
So then 3 hours followed by 1 to 2 hours of break, changing position to lateral or a supine position, and then going back to prone position.
Yes.
Okay. And this is what we started to discuss during the first part of our talk. this, I think it's the stepwise approach and that you introduced before. I think it's a very interesting approach. Can you please maybe elaborate on this particular slide?
Yeah, so the first step is oxygen support. And that is based both on saturation and respiratory rate. And generally, it's low flow oxygen, 1 to 2 liters a minute. Then, if that is insufficient, going to 3 to 4 liters per minute. Once you're at 4 liters per minute and you notice that the patient is still tachypneic or using accessory muscles, so has increased work of breathing, then there should be consideration for support with non-invasive. There you might consider high flow, and when I say high flow, I'm talking about more 25 liters per minute or above, but using a special high humidity, high flow circuit, or might be more successful using a CPAP, continuous positive airway pressure system, either nasal or full face mask, or as you saw, there's some with total hoods.
Yes, with the helmets, yeah.
With the helmets.
Yeah, with the helmets. Would you agree with the recommendations? They're partly derived from the German paper, which both you and I read with interest in the past few days.
Yes, it was quite thorough. You can see that there is in this paper some variation in thought, but I think keeping in mind a threshold of 4 liters per minute, that if the patient needs above that, that then it is time to step up management and support.
Okay, and we also have a slide that some people may already be on CPAP, non-invasive ventilation. They may use it because of COPD or because of obstructive sleep apnea. And I believe there was a recommendation, do not stop it if you're already using it, but take precautions so that because non-invasive ventilation is known to generate aerosols. So there is a concern about the patient safety, if it's in household, then the safety of the relatives, of the family, the nearest family, and of the medical personnel if it's done in a hospital. Could you comment on
so patients who are on chronic ventilation or even CPAP have it for a reason. They will be sicker without this therapy.
Exactly.
Most of these patients are already well recognized to self-isolate. So they are more at risk from somebody bringing in COVID into their household than giving COVID to somebody. They should continue on that therapy. If they happen to need hospitalization, I agree with the article that suggests they should not use their home circuit because that might be infected, but be given a new circuit, and that the hospital personnel have to recognize that use of this CPAP or BiPAP is aerosol generating, and that appropriate precautions should be taken. But these patients are likely to do worse if you stop this therapy than if you continue this therapy. And the only concern is aerosol generation, and we have, protocols in place, and we know how to protect ourselves for patients who are aerosol generating.
And during the first part of our talk, you introduced an idea of converting some hospital rooms into negative pressure rooms.
Yes, that can be done. And if that cannot be done, well, even if it can be done, then personnel still have to take precautions. These are aerosol generating, and so the person have to be dressed appropriately, including N95 masks. And at the least, maybe there should be a temporary antechamber attached to the room so that when the door of the room is open, there is not exposure to the aerosols generated in the room going out into the corridor.
When this video will be posted on YouTube, I will make sure to update the slides with the schematics of the antechamber, as well as cite the paper that we're discussing right now in more detail, because it includes some interesting discussion, which I imagine would be very helpful for the colleagues in Kazakhstan.
I agree.
And this is just for our audience, the different forms, different masks, type of mask, including the helmet on this figure. And we also have a slide about comparison between CPAP and BiPAP. If you could you please say a couple of words, difference between.
So the CPAP is a continuous positive area pressure. So there's a continuous flow. There's the patient wears a mask. Often these masks have a small vent so that there is some escape, and that can lead to aerosol generation. But it's meant that the pressure in the circuit is constant. So that's where the C comes from, or continuous.
Okay, here.
BiPAP is bi-level positive airway pressure, so that the device provides a basal pressure, and then either at a set rate or when the patient generates a respiratory effort, then a higher pressure is given. And so it's a two-level pressure system that is used and provides non-invasive ventilation. And generally, the basal pressures were somewhere probably between 6 and 10 centimeters of water, and the higher pressures will be somewhere generally between 16, 18 up to 22, 24 centimeters of water.
Any comment on why CPAP is favored for patients with severe COVID-19 and ARDS over BiPAP?
CPAP is generally more comfortable. Patients take to it more readily. The idea is to try and help recruit areas that have had volume loss, and also to decrease the inspiratory work of breathing. BiPAP, again, can do the same things, but even help the inspiratory work of breathing more. However, it is a more complicated system, and patients have to adapt to it somewhat more than a CPAP circuit.
And in terms of personnel, what's easier to administer?
The CPAP system is simple because once the pressure is set, and as long as there's no leaks in the system should deliver the continuous pressure. The BiPAP, as the patient changes, then there needs to be much more frequent surveillance of the delivered pressures and the tolerance of the patient. You certainly want to avoid over-ventilation. And as the patient evolves, you have to adjust, especially both the upper pressure and the lower pressure. So it takes more expertise.
And in patients with ARDS due to COVID-19, for how long would you consider using CPAP or high flow oxygen until considering putting them on ventilator, on invasive ventilator?
I think a variety of factors need to be taken into. You have to judge: does the patient look like they're heading into fatigue, which is again use of accessory muscles. In adults, certainly paradoxical breathing, where the chest rises and the abdomen comes in, or where the abdomen goes out and the chest pulls in, which is a sign that the respiratory muscles are tiring. Carbon dioxide, PCO2 elevation is something that occurs a little later. And by the time the CO2 is rising, it's becoming very urgent. And careful monitoring of the patient in terms of their vital signs, saturation, respiratory effort will give a indication of when to move forward. Also, as we previously discussed, there are scores looking at the FiO2
Yes.
to arterial partial pressure. Again, a very good guide as to how your patient is progressing, whether they're improving, stable, or getting worse.
Thank you for this very comprehensive comment. I think our audience will also appreciate the fact that you and I discussed before the first part of our video conference that there is a need to treat a patient, not just follow the guidelines, because especially with ARDS and COVID-19, each patient is different.
Yes, and there's different stages, which we will talk about shortly, and these have to be recognized so that appropriate support is given at a given time for an individual patient.
Excellent, thank you. And that's probably the most complicated part of our talk, which is invasive ventilation, and what's anything that raises your attention in the question of in the tracheal intubation. And
so the only point I will emphasize on this slide is that intubation is a major aerosol generating activity, and the personnel have to be properly protected and recognized. Out of all the procedures we do, this is one of the highest aerosol generating procedures.
Exactly. So these are the phases that you mentioned previously, the phases of...
In some ways, using the term ARDS for COVID is misleading. There are two types of disease, one that occurs earlier and one that occurs later. The earlier phase, which you'll see the ground glass opacities on X-ray, possibly other opacities, tends to be a lung that is still relatively dry and has a good compliance, and which has surprised most intensive care doctors, because when COVID-19 first started, people thought, oh, this is just ARDS, but it's not. The early phase is characterized by a relatively dry lung, not the capillary leak syndrome, and that the lung is relatively compliant. And so what's being suggested in that situation, that the positive end expiratory pressure be relatively low, 8 to 10 centimeters of water, and that the lung volumes be given, again, are more on the normal side, 6 to 8 milliliters per kilo for each breath.
Yeah, I think we have a special slide.
I think we're going to get yeah. And so as the slide you had up, it says very much to avoid alveolar distension, and that is why you do not want to use overly large breaths. But in this early phase, it's the breaths tend to be more normal size compared to the second phase of COVID respiratory disease, which is more like ARDS, where there is capillary leak, there is a lot of fluid, and so people tend to use PEEP, slightly higher peaks and lower lung volumes.
Speaking of the slide, so what's the role? We know that the role of inhaled nitric oxide is very pleiotropic, ranging from vasodilation and going all the way up to being antiviral. What's the caution? What's the precaution here? Why inhaled nitric oxide is not recommended routinely?
It certainly will vasodilate, and it might not per se increase oxygenation. If it's not increasing oxygenation, then or possibly worsening oxygenation, then it shouldn't be used. Absorbed systemically, it can certainly also cause peripheral dilatation and loss of systemic blood pressure, and so might alter perfusion. And already there are concerns with perfusion, and as we'll talk about a little later, hypercoagulability. So it could be problematic. So nitric oxide hasn't seemed to be helpful in this situation.
Excellent comment. And since you mentioned other forms of management in severe COVID-19, we addressed pronation of the patient. We briefly addressed other pharmacology, sedation, neuromuscular blockade, vasopression. There is a big debate going on at the moment about the use of anticoagulants.
So it's now recognized that there is a risk for a hypercoagulable state that's been seen in the adults. And this can cause cardiac disease, central neurologic disease with even a development of small strokes, and kidney disease as well. And so at the least, patients should be put on standard low molecular weight heparin prophylactic anticoagulation. So they don't need to be fully anticoagulated, but the standard prophylactic that is very often used, let's say in surgical patients.
Right. This is not surprising because there've been early studies about the importance of anticoagulation, but not in larger vessels, probably in capillaries, and that explains what we discussed earlier, that the lung is fully compliant and yet there is hypoxemia. Do you think all these measures, that anticoagulation measures that are actually aiming for, as you mentioned, surgical procedures, will also be applicable to the lung, will also be applicable to the vessels in the lung?
Yes, thanks for bringing it up. Part of the hypoxemia that's been seen in the early phases of COVID-19 is probably due to microthrombi in the capillaries.
Right.
And so that there's worsening of ventilation perfusion matching. Yes, this can help prevent that.
Okay, excellent. So you are in favor, just to summarize, you're in favor of having prophylaxis, some prophylactic anticoagulation?
It seems to have prevented a number of complications.
Okay, that's something, the topic that you and I love very much. It's the use of anti-inflammatory therapies in the presence of viral infection. And this is because another ongoing debate is potential benefit of low-dose corticosteroids in ARDS, especially in ventilated patients. you and I discussed briefly about the inflammatory cascade in COVID-19. So if could you give a couple of commentary words on this slide?
So it is now recognized that COVID-19 in the early phase, let's say in the first 7 to up to 10 days, it's primarily viral replication. And then there is an onset, a progressive onset of an inflammatory component, not in all patients, but in some patients, particularly starting after day 7, that the most extreme form, people have thrown around the term cytokine storm, but certainly a massive release of many pro-inflammatory mediators, as you can see on the slide, IL-6, IL-10, TNF. And these, again, will recruit in pro-inflammatory cells and lead to secondary damage due to poorly controlled, poorly regulated inflammation.
And also in the remote organs, not just in the lung, because
yes.
These are soluble factors. They can dissipate through blood to other organs and cause damage.
Yes, this is a systemic response. It is not, it might be generated by lung disease,
exactly.
But these factors go everywhere.
So we'll probably see systemic consequences of this. On the other hand, I imagine you would have reservations about the use of corticosteroids, especially given that they also have immunosuppressive effects. And we deal with viral replication going on at the same time.
So corticosteroids very much are a double-edged sword because we do know that they will interfere with immune responses and early immune responses to viral infections, with evidence in other diseases, other viral infections to the lung that can actually worsen outcomes with corticosteroids. And so while people recognize that there was this inflammatory component, and people think first in terms of anti-inflammatories of corticosteroids, it was debated, could it be useful? If so, when it could be useful? And this led to a large trial in the United Kingdom.
Okay, and we have the results of this study presented on the slide.
And they used, in this study, they took patients who were being hospitalized for COVID-19, and they used dexamethasone at a relatively low dose, 6 milligrams once a day, for up to 10 days. They did not have a placebo, but they compared it to usual care. It was a large trial. As you can see, there was over 2,000 patients in dexamethasone and 4,000 in usual care. Looking at this forest plot, you can see that those patients who did not need oxygen on entry into the study did not benefit. Exactly. It is those who were on oxygen, and particularly those who are on ventilation.
Yes.
But more important, or as important, a concomitant finding was that it seemed helpful in those who had symptoms for more than 7 days. And it did not help those who had symptoms less than 7 days. And I think this reflects the nature of the disease. As we discussed, in the first week, there is a lot of viral replication.
Right.
Whereas it's after 1 week that you start to have the inflammatory component.
Right.
So if you were, and the benefit of dexamethasone is that it's widely available and very inexpensive. However, I think it should be reserved for those who have both symptoms for more than 7 days and who require oxygen. I think there's a risk in using it in much milder patients or with patients who have symptoms for a shorter period of time, because that might be in the time when the virus is replicating, and you might interfere with the natural antiviral defenses.
So the safest bet would probably to use it in intubated patients, because at that moment, first of all, these patients benefited the most out of all these three groups. And also because we know for a fact that these patients are most frequently have these, what you call this, or what is called commonly as a cytokine storm. So that's
yes, and like I said, I'd certainly, like I say, reserve it for patients who have symptoms for at least a week and are needing oxygen, especially if you see that their oxygen needs are starting to go up or towards intubation and ventilation.
It's also interesting because from classical, that means non-COVID-19 associated ARDS, we know for a fact that there are two groups of patients or two cohorts of patients. The patients with lower inflammatory levels of inflammatory markers, so-called hyper-inflamed patients, and the patients with hyperinflammation, which have very high levels of interleukin 6, interleukin 8, TNF-alpha, and so on. Unfortunately, there are no tools available, no bedside tools to rapidly screen for example, systemic levels of IL-6, IL-8. I recall a study that actually used regular lab parameters and patient parameters as a classifier. They even used machine learning approaches. We can also post a link to that paper on our YouTube video. So the bottom line is, even with classical ARDS, there is heterogeneity of patients. Would you think that heterogeneity of patients with severe COVID-19 would be even more exaggerated because now we have another factor at play, which is the virus?
Yes, and as I said, the early phase of severe disease tends to be dry and good compliance, whereas the later phase is more of a capillary leak and a low compliance disease. So it's a progression and it's a spectrum. And as a matter of fact, very hard to separate the two groups because people move not in one step from one phase to another, but there is a continuum along the way. However, I think as we understand now, to reserve invasive ventilation for those who really need it, i.e. they're at risk for impending cardiorespiratory failure, I think this may have contributed to why the corticosteroids were successful, because they reserved it for those who, when they intubated, they really needed intubation and mechanical ventilation.
This is, you're bringing up a very interesting point. We need to carefully review this. This paper was from the United Kingdom. I imagine that there can be different differences in inclusion criteria for this particular study, and also for the patient to transit from how the patient are transiting from oxygen to invasive ventilation. If I understand it correctly, you just addressed you just expressed some cautionary note that not just to take this for a fact that these patients are ventilated and therefore are benefiting from dexamethasone. They could have been pre-selected based on the British criteria for invasive ventilation. Do I understand this correctly?
Yes, there is also, if their treating physician felt that the patient was at risk for complications from steroids, then they were not included in the trial. So there is some selection bias.
Okay.
Nevertheless, the results, I think, have surprised most of us. Although in understanding the time course of the disease, like I said, if the patient has symptoms for more than a week, particularly if their oxygen requirements are going up, then they would most likely benefit from corticosteroids. This is one trial using one particular dose of dexamethasone.
Right.
Is it the right dose of dexamethasone? We do not know. Is more better or is more harmful? We do not know, but it's a start.
Okay. Okay. And would you, if you have a couple of more minutes to address a couple of questions that came from our audience. One of the questions was concerning the management of pregnant women who are COVID-19 positive, delivery strategies, and how to deal, or how the newborns will be handled.
Okay. In our own hospital, anyone coming to deliver is certainly screened for COVID, and we can get a result. If it's early in the day, we can get a result the same day, if not the next day. So people are considered COVID suspect until ruled out. If the mother is known to have COVID-19, then if the baby is, again, the whole team must take precautions with aerosol generation.
Right.
The delivery happens as usual, and if the child is well, then the child will stay in the same room as the mother. If the child requires more care, then the child is transferred to the neonatal intensive care unit. Again, the child is swabbed. Full precautions are done for 24 hours, including N95. If the swabs come back negative, then again, precautions still continue, except instead of an N95, a surgical mask is used by the staff.
Okay. It's adequate in that case, a surgical mask instead of N95.
Yes, but
sufficient,
but they do rule out that the baby doesn't have COVID or not. To date, as we talked about in our earlier sessions, transmission seems to be postnatally and not intrauterine.
Okay, thank you. And our last question, first we received a comment from the audience that the schools, apparently the schools in Kazakhstan are, the reopening of the schools will be postponed until probably in January. If I understand correctly, I received this notification, I received this comment. Would you have any recommendations for the Department of Preschool and School Education about school opening and risk groups of children? Do you have any recommendations how to avoid infection and how to avoid fatalities associated with COVID-19?
So we've had numerous discussions actually as an international group towards schools, and various jurisdictions have tried to open or maintain their schools, some more successfully than others. For example, Hong Kong has been quite successful. Denmark has been quite successful, whereas Israel had to reclose down schools. Certainly, we talked previously about transmissibility. Children above the age of 10 seem to transmit virus more than younger children. That does not mean that younger children still cannot transmit. Even preschool children, about 10% of those cases seem to have indication of the child being able to transmit, whereas 90% it was the child getting the virus from an adult. So I think there will definitely need to be good hand washing, masks. There probably has to be social distancing in the schools. This is all going to be problematic. There might have to be schools happening on a part-time basis. We realize both the educational aspect and the social aspect of school and contact with children of their own age is very important, particularly in adolescence. And it will also partly depend on what the local situation is in terms of how active the infection is in the community. So in communities that have very little infection will be able to open more and allow more children to attend, whereas communities where there is lots of infection or infections are on the rise will require much more strict. So even in our own province, where I live in Montreal, we had a lot of COVID, and so they did not open the schools and will only restart the school in September, and people are still uncertain if that is safe. Whereas communities outside of Montreal, where there was very little COVID, they did resume school in May. So you need to keep in the context of what is happening locally, and locally can be very local, not even at a countrywide or a statewide, but it might be more individual cities. There's something else I want to say.
A patient who potentially not patients, kids who are children who are potentially vulnerable, risk groups. Would you consider them? Would you recommend them staying at home, going to school, or that will depend on situation?
Okay, so the other point I want to make in general, you do need a program of testing and contact tracing and isolation. There will be outbreaks. Even in South Korea, who was very successful at locking down, they still have outbreaks, but they have one of the best systems of testing, contact tracing, and isolation. So that is a key component to limiting the size of outbreaks. So I'm not saying we won't have outbreaks, but you do want to limit their size. Are there populations at risk? Yes, there are. Patients who are immune suppressed are going to be at risk. Patients with certain chronic diseases, severe lung disease. In general, for asthma, the majority, meaning about 90% of children with asthma should be able to go at school. That's not to say they won't get infected, but they're not necessarily having worse disease. I was just on a phone discussion yesterday where an American group who looks after vulnerable children, vulnerable from a social economic status, is going to analyze their data as to what has happened with asthma control. And this, I think, is in Boston, so a large city where there was a lot of COVID. So we are all learning, as people say, flying the plane while we
Yes.
were building it. So we are all learning, and recommendations may change. Children who need ventilation, let's say children with neuromuscular disease, they are certainly going to be at risk. But these families understand isolation. They've been doing it well before COVID.
Right, right. And with this, we'll let our hostess to wrap up the session. And on behalf of the organizers and myself, I would like to express our sincere gratitudes for you taking this time and elaborating on all these important issues. And this is for the second time now. We've done the first video conference on April 30th. That was when we addressed pediatric COVID-19, and now we talked about ventilation and non-invasive ventilation. And I think our colleagues in Kazakhstan will really appreciate your input, your great input. Again, thank you for all this information and sharing with us your expertise.
My pleasure.
Өте қызықты және мазмұнды пікірталас үшін көп рахмет. Большое спасибо за эту очень интересную и информативную дискуссию. Құрметті көрермендер, біздің кездесуімізді аяқтай отырып, баяндамашы профессор Ларри Ленски конференцияға қатысқан үшін және тақырыбындағы өзекті сұрақтарға жауап алуға мүмкіндік бергендері үшін ерекше алғыс. Бізді байланыстырып Galamdyq-sheshim KZ YouTube каналынан көрген конференция қатысушыларына алғыс айтамыз. Біздің Әл-Фараби атындағы Қазақ ұлттық университетіне және Канададағы Қазақстан елшілігіне осы бейнеконференцияны ұйымдастыруға үлкен көмек көрсеткені үшін алғысымды білдіремін. Модераторымыз профессор Дәулетбаевқа көп алғыс айтамын. Біздің әйгілі қонаққа профессор Ларри Ленски ерекше алғыс айтамыз. Сіз бүгін біздің спикер атанғанымызға өте қуаныштымыз. Мы хотели бы поблагодарить Казахский национальный университет имени Аль-Фараби и посольство Казахстана в Канаде за большую помощь в организации этой конференции. Большую благодарность выражаем нашему модератору, профессору Дәулетбаеву. Особую благодарность хотим сказать нашему знаменитому гостю, профессору Ларри Ленсу. Мы были очень рады, что вы были нашим спикером. Біздің Galamdyq-sheshim.kz ақпараттық каналымыз жұмысын жалғастыруда. Сұрақтарыңыз бен қызығушылық танытқан тақырыптарыңызды Galamdyq-sheshim.kz @gmail.com поштасына жіберіңіз. Сау болыңыз және өзіңізді сақтаңыз. Уважаемые зрители, завершая нашу встречу, позвольте еще раз поблагодарить нашего спикера, профессора Ларри Ленса, за участие в конференции и возможность получить ответы на актуальные вопросы. Благодарим участников конференции, кто был на связи и смотрит нас на YouTube-канале Galamdyq-sheshim.kz. Наш информационный канал Galamdyq-sheshim.kz продолжает работать. Ваши вопросы и интересующиеся темы высылайте на почту galamdyq-sheshim.kz@gmail.com. Будьте здоровы и берегите себя. Спасибо.
Thank you.
Thank you, everyone.
Thank you so much.
Okay, it's a pleasure.
Okay.
Take care.
Have a great day. Bye-bye.
You too.
Bye-bye.